Hi, and welcome back to the WHY-O-MYO podcast. This is Janine Steen, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. During our last podcast, we spoke mostly about anterior tongue ties. Today I'm going to focus more on posterior tongue ties. So just to recap, an anterior tongue tie is typically when the tip of a person's tongue is attached behind or between the lower dentition to the gum behind the lower teeth. Oftentimes, it is evident when the patient tries to stick out their tongue. They may not be able to stick their tongue tip out all the way. It may have a dimple or a heart shape at the tip. It also is something that is easily identifiable by in most situations, and often can be identified early, especially if a parent or an infant is reporting that they're having difficulty latching or failure to thrive, gassiness, colic, issues associated with infant feeding. The difference between an anterior tongue tie and a posterior tongue tie is the posterior tongue tie is not often easily identified and is not something that is often identified early unless or until it's truly affecting a specific area, such as the hard palate, the production of sounds, and even affecting the development of the oral cavity. The difference between an anterior and posterior tongue tie is that anterior tongue tie, you can truly see the restriction and the inability of that tongue tip to move well, whereas a posterior tongue tie can be more obscure and more difficult to identify. Posterior tongue ties are not uncommon when we see patients that have tongue thrusts and are in need of myofunctional therapy, and are often a restriction that has an impact on the palate, an individual's swallow, as well as having that same effect on the temporomandibular joint due to compensatory techniques and issues with tongue-jaw dissociation. One of the symptoms or one of the issues that are often an easy way to say, okay, my child may or my patient may have a posterior tongue tie is that they're unable to click their tongue. So they're unable to make that sound, or when they do make that sound, it sounds hollow. It doesn't, and that hollow sound is because the mid portion or the tongue blade is unable to make contact with the hard palate because the frenum is restricting it. So when we are trying to identify if a patient has a posterior tongue tie, one thing we do ask them to do is to click their tongue. The other thing we ask them to do is to try and click their tongue, but to get it stuck right in the middle of that click, and see if the patient is able to get the tongue to suction to the hard palate and hold it there. This is definitely a difficult task, and it's something that we work on for an extended period of time in therapy. So it's often not something that is easy to condition in terms of evaluating a patient or as one of the evaluating criteria for a posterior tongue tie. So another way that we identify or assess if a patient has a posterior tongue tie is similar to an anterior tongue tie, but again, we take our gloved finger and we swipe underneath the tongue, and we look to see if we feel a restriction. If when you swipe under the tongue, you actually come up against some resistance, that often is a sign that your patient or your child has a posterior tongue tie. A posterior tongue tie in and of itself is not problematic. It's the symptoms or the issues that occur secondary to that posterior tongue tie. So for example, our individuals that do come in for evaluations, specifically myofunctional therapy evaluations, patients that have a posterior tongue tie tend to be tongue thrusters, and tend to allow or need to rely on their tongue tip to do all the work, meaning their tongue tip is responsible for managing saliva, it's responsible for articulating sounds, and it is responsible for swallowing. So a patient that has a posterior tongue tie is unable to speak and swallow simultaneously. And that's often secondary to their tongue thrust, but also because their tongue tip is responsible for the speaking part, and it's also responsible for the management of saliva. And that management of saliva really requires the back of the tongue or the base of the tongue to be swallowing while that tongue tip is otherwise engaged, whether it be in communicating or speaking, or management of food. Another symptom of a posterior tongue tie often occurs when a patient is chewing, and after they swallow one time, they have a ton of residue or a ton of leftover food, not just on their tongue, but now has fallen within their cheeks. It's stuck to the top of their mouth. It's in the buccal and labial cavities. It's stuck in the dentition. And the issue or the reason for this is that when we swallow, in order to control the food and in order for us to control that the food we are swallowing goes down in an appropriate way and we clear the food from our oral cavity, when that tongue blade cannot make contact with the hard palate, well, that food is not being controlled in that space. So if the food is not being controlled in that space or in that area of the tongue, the food then can fall. It can fall into the cheeks or into the buccal cavities. It can fall posterior and put that patient at a risk for choking. It can fall anterior, which now requires, it may result in the food coming out of their mouth, having residue or food on their lips, on their chin, becoming messy eaters. So in order for us to be able to rectify those concerns, it will also be necessary to release or have a frenectomy so that we can recondition and establish and strengthen the patient's swallow and extinguish their tongue thrust swallow and establish their mature swallow pattern. Another identifying characteristic of a potential posterior tongue tie is patients that have a high vaulted palate. When your palate is high and vaulted, it is because you're a tongue thruster for the most part, and at rest and when swallowing, your tongue is not able to fit within the confines of the palate. So as that tongue continues to push on the palate, that palate is malleable until you're done growing. So that means it can be moved and shaped, well into latter teens, early adulthood for boys, and thus creating this high vaulted palate, which limits the ability for the tongue to fit within that palate. It also limits the amount of surface area and control that individual has when it comes to chewing and swallowing specific foods. Lastly, one of the identifying characteristics we often see with posterior tongue tie patients is just some picky eating type scenarios, and that's mostly because their tongue tip has become so desensitized from doing all the work, meeting all the foods that are being introduced, meeting all the liquids that are being introduced, meeting all the temperatures and the consistencies, and the level of taste, that once the food falls or makes it to the middle or tongue blade, where it is often being pulled or restricted from the underside of the tongue, that area is often hypersensitive. And that's just because there's very seldom a time where the food texture, consistency is sitting in that area of the tongue, and or being controlled in that area of the tongue. It ultimately will bypass that area of the tongue, especially when that posterior tongue tie causes a restriction that limits the contact of the tongue blade and the hard palate. It is also really important to remember that if a patient has a posterior tongue tie and is unable to make contact with the tongue blade and hard palate, that individual will be unable to shape their palate in an appropriate way. So when your tongue blade can fit within the confines of the palate perfectly, like a puzzle piece, that contact between the muscle of the tongue and the bone of the hard palate helps to shape the oral cavity and create enough space in your mouth so that everything can fit snugly and operate as it needs to. When you're tongue-tied, and this could be for an anterior tongue tie as well, but with a posterior tongue tie, if you are using your, unable to use your tongue blade to make that contact, A, for swallowing, but B, at all, then there's very seldom a chance that that tongue blade is going to be able to help support the shape and the size and shape of the hard palate. These patients are often the patients that we recommend or make referrals for palate expansion because we need more space in their oral cavity in order to condition their tongue and strengthen their tongue. And oftentimes that is post-lingual frenectomy. Now, there is times that we can quote unquote stretch the frenum. However, the stretching of the frenum is a little bit misconstrued in the sense that most often the stretching of the frenum has a lot more to do with the tongue, our ability to work with the tongue to dissociate the movements of the tongue and dissociate the movements of the tongue and jaw, so that now it appears that we're getting this greater range of motion, thus stretching the frenum. We will give this we will work on this for a few sessions to see if we can condition and if we feel that by conditioning the tongue to do this and do it well, if it's going to make up for that posterior tongue tie. And there's no crystal ball. Sometimes it does, sometimes it doesn't. It depends completely on the patient and the individual. I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.